Welcome to the grand finale of our 10-part explainer. Today's the day we tackle the ultimate final boss operative report. This is a highly complex, high-risk case that's going to test literally everything we've covered so far. By the end of this session, we'll forge your everyday master coding checklist. Let's get right into it.
For our agenda today, we've got 1. The ultimate coding challenge. 2. Primary procedure, radical excision. 3. Unbundling secondary distinct procedures. 4. The master neurosurgery coding blueprint. And 5. Series finale, empowering checklist.
Section 1. The ultimate coding challenge, high-risk recurrent pituitary adenoma. All right, set the scene. We're looking at a patient presenting with a massive, invasive recurrent pituitary adenoma. They're undergoing a multi-specialty endoscopic transsphenoidal reexploration. Now the clinical dictation reads, patient positioned, massive recurrent tumor identified, initiating transsphenoidal reexploration. The stakes are incredibly high here, right? An invasive recurrent tumor means distorted anatomy and a ton of scar tissue. We have to read deep into the surgeon's operative note to extract the absolute clinical truth. Section 2, Primary Procedure, Radical Excision. Our absolute first objective is isolating the primary surgical intervention from all that dense dictation. To do this, we always determine the entry point. Ask yourself, did the surgeon break the wall, meaning they opened the skull via a craniotomy, or did they use the window, meaning they went through a natural orifice, like the nose, for a transsphenoidal approach? In our case, the operative note specifically mentions a transnasal approach with a sphenoidotomy and radical tumor excision. But we really need to pinpoint the exact technique. Was it the traditional microscopic method without a camera? If so, we look at CPT 6154. Or was it an endoscopic, camera-assisted approach? Well, the documentation explicitly confirms it was endoscopic. So that immediately directs us to assign CPT 6265 as our primary procedure. Section 3. Unbundling secondary distinct procedures. Finding that primary code is just the beginning. An expert auditor meticulously scours the rest of the report for secondary interventions. This incredibly complex session requires tracking the surgeon through 3 very distinct phases. Step 1, the primary tumor excision we just locked in. Step 2, therapeutic spinal fluid management. And Step 3, a separate reconstructive tissue harvest. Looking closer at the clinical note, it details the pre-positioning placement of a lumbar subarachnoid catheter using a specialized Tuhe needle. So why exactly is this done? It's for controlled cerebral spinal fluid drainage and intracranial pressure manipulation during the tumor removal. Because this therapeutic spinal puncture is an entirely separate intervention from the cranial work, it beautifully justifies assigning CPT 622272. But wait, there is more. As the procedure wraps up, the documentation indicates a separate transverse incision down in the abdomen. The surgeon harvested an autologous dermal fascial fat graft to place directly into the sella turcica, that's the cavity where the tumor used to be, to reconstruct the surgical defect. This separate tissue harvesting unlocks CPT 15769. Now, here is the absolute golden rule of unbundling under neurosurgical guidelines. We have the intracranial sella for the primary excision, the lumbar spine for the CSF drainage, and the abdomen for the fat graft. Because these procedures occurred at 3 completely separate anatomical body sites, they entirely bypass standard bundling edits, which means they are legally, compliantly billed independently. Section 4. Master Neurosurgery Coding Blueprint. Having conquered that final boss operative report, it's time to distill everything we've covered in this course into our master blueprint. These 4 immutable principles are going to guide you through the chaos of literally any surgical dictation. Principle 1 is foundational. The operative report is your ground truth. You have to read beyond the procedure title, straight into the body of the note to determine the true surgical intent, the exact anatomical depth, and the specific pathology. Principle 2 demands strict anatomical zoning. Always categorize the surgical compartment first. Are we supratentorial, guiding us toward codes like 61510 or 61512? Are we infratentorial in the posterior fossa, pointing to 61518, 61519, or 61520? Or are we dealing with a transsphenoidal sellar approach, or maybe a complex skull-based procedure from the 61580 to 6116 range? Isolate the zone first, and you instantly narrow your options. Principle 3, forces you to distinguish between bundled and unbundled interventions. Remember, standard surgical access, things like routine bone flap creation, burr holes, and basic dural closure, is bundled right into the primary code. However, highly specific secondary interventions are independently billable. We're talking about things like the therapeutic CSF drainage we just saw, graft harvesting, stereotactic navigation using add-on codes 61781 or 61782, and the operating microscope, code 69990. Finally, Principle 4 emphasizes the reconstructive hierarchy. Accurate coding heavily depends on post-resection details. For instance, if the surgeon is repairing a dural CSF leak, did they use a free tissue graft taken without its blood supply? That's 61618. Or did they use a vascularized pedicle flap that retains its blood supply for better healing? That's 61619. This hierarchy applies everywhere, from cranioplasty defect sizing, like under or over 5 centimeters, to complex encephalocele corrections.
Section 5. Series Finale, Empowering Checklist. To ensure absolute precision every single day, this blueprint has to translate into an actionable workflow. From the exact moment a chart opens, follow this exact progression. First, read the operative note for intent. Second, zone the anatomy by compartment. Third, identify distinct unbundled interventions. And fourth, code the reconstructive hierarchy. That right there is your everyday decision-making checklist. Never forget this core truth. The operative report tells exactly what the surgeon did, and it's the absolute most important document for selecting the correct CPT codes. You are the definitive auditor of that surgical narrative. Your mastery of this documentation translates incredibly complex, high-stakes medical interventions into accurate, compliant coding. The surgeon literally relies on you to capture the full scope of their life-saving work. So, are you ready to conquer the operative narrative and master neurosurgery coding? Take these 4 principles, apply them with unyielding confidence to every single operative report you review. You've got the knowledge, you've got the blueprint, and you absolutely have the expertise to excel. Thank you so much for joining me on this incredible 10-part journey. Now get out there and decode healthcare with Harshal.